Anterior lumbar interbody fusion is a surgical technique that surgeons will use to treat degenerative conditions of the spine, typically severe disc degeneration and disc collapse, which causes severe back pain. When that happens, it also typically will cause nerve compression. As the disc collapses, it will bulge back, bone spurs can grow, and that can cause nerve compression. So patients who are good candidates for anterior lumbar interbody fusion are typically patients with severe back and leg pain caused by these degenerative conditions. Another condition that very commonly is treated with the ALIF or anterior interbody fusion surgery is patients who have a spondylolisthesis. Spondylolisthesis is a condition where one bone will start to slip forward on top of the other. That can be caused by one of two things: either severe arthritis, which leads to unstable joints, or in some cases, patients may have a condition called a pars fracture, which is a congenital fracture of the spine that develops very early in life, which leads to instability. The anterior lumbar interbody fusion is done through an incision in the lower abdomen. So we're approaching the spine from the front. The word anterior means from the front, as opposed to a posterior procedure, which is done from the back. In many cases, the spine surgeon will use another surgeon to assist the surgeon during the exposure of the spine. I typically will have an abdominal surgeon assist me during the procedure. The abdominal surgeon will make the incision in the lower abdomen, provide the exposure to get to the spine, and then once we're down to the spine, then I pretty much take over the case at that point. Once we're down onto the spine, then the disc that has degenerated and collapsed or that has become unstable, that disc is completely removed. By removing all of that disc material, number one, it allows for the surgeon to remove pressure on nerves that are being pinched. It also creates a nice space between the bones to allow for placement of a fusion device, or what we typically call a fusion cage. A fusion cage is for an anterior interbody fusion. A fusion cage is typically a cylindrical device, typically made from either plastic or titanium. And so this is a titanium fusion device that I typically use in my cases. The device is hollow in the middle, and I fill it with bone graft material, and that device then slides into position and sits where the disc used to be. The device basically allows for restoration of height of the space between the bones. It also allows for restoration of alignment or realignment of the bones that have become out of position. And then once that device is in its final position, in many cases it is locked in place with screws that are placed through the device into the bones above and below. In some cases, the surgeon may be done with the procedure at that point, or the surgeon may make additional incisions in the back to place screws and rods in from the back. In some cases, the ALIF procedure is part of a larger procedure where the surgeon will approach one, two, or more discs from the front, and then choose to approach additional discs from the side or maybe from the back, and then screws and rods are placed from the back. This is typically done in a situation where a patient has multi-level degeneration or sometimes a scoliosis, where the surgeon needs to use the cages in the front and screws and rods in the back to straighten the spine and stabilize it. As far as the risks of surgery, the risks of an anterior lumbar interbody fusion can be broken into three categories. Category one is risks of anesthesia, because you do have to be put to sleep for the procedure. Category two is risk of things that can happen during the operation. And then category three is things that can happen after the fact. Risks of anesthesia are low but not zero. Things can happen. Allergic reaction to medication, the possibility of seizures, heart attack, stroke, even death is a risk from the anesthetic, although it's highly unlikely. Every individual, of course, need to get their individual risk profile from a discussion with your surgeon, a discussion with your probably primary care physician, and maybe a cardiologist. And of course, there are many tests that are run prior to surgery, including blood work, chest x-ray, EKG, to make sure that you're at not undue risk for anesthesia. During the operation, there are risks of injury to structures within the abdomen, between the skin and the spine that we're close to as we're performing the surgery. That includes risk of injury to the intestines, potentially. There's risk of injury to the tubes that carry urine from your kidneys to your bladder. Those structures are called the ureters, and those structures are potentially at risk. There are major blood vessels that travel to and from the heart that travel right in front of the spine, and those structures are potentially at risk as well. That could lead to significant blood loss and potentially major complications such as death in rare instances. One of the reasons why many spine surgeons use an abdominal surgeon or sometimes a vascular surgeon for these procedures is to try to reduce that risk and, of course, address any complications that may occur. After the surgery, there's risk of infection. Anytime you have a surgical incision, there's about a 1% risk of infection. There's also risk of the fusion not healing. We're trying to get the bones to grow together and unite together and become one, kind of like welding two pieces of metal together. And in some cases, the bones don't form a good solid fusion. That may happen in anywhere from 2 to 5% of cases. If that were to happen, it could potentially lead to loosening of the implants, which may require additional surgery. The anterior interbody fusion surgery, if one disc alone is being fused, typically is about a 1.5 to 2 hour operation. In some cases, patients can go home the same day. In some cases, patients may spend one night in the hospital. Before the patient leaves the hospital or the surgery center, they typically are able to walk, they're able to climb stairs, they do not have to go home and be on strict bed rest. Most patients are back to driving themselves, back to office work, sitting at a desk, usually around 2 weeks or so after surgery, in some cases 3 weeks, depending again on the number of discs that are being fused. It takes about 3 months for the bone fusion to start to get solid enough to where I am comfortable allowing patients to start some physical therapy for back strengthening, core strengthening, stretching, and range of motion exercises. Once patients have started the physical therapy, after about 3 to 4 weeks of physical therapy, that's generally when I will allow patients to return to full activity without restrictions. And that includes everything from golf, tennis, back to the gym, martial arts, running, skiing, essentially any recreational or exercise activity that they want to get back to. As long as that fusion is solid and looks good on x-rays and they're doing well, I allow patients to go back to those activities. As an example, Tiger Woods had an anterior lumbar interbody fusion and 2 years later won the Masters. So he obviously went through a lot of recovery, did a lot of rehab. He was obviously in very good shape beforehand and an excellent golfer. But he was able to return to a very high level of athletic competition following his anterior lumbar fusion surgery.